Yeah. So we begin with our CME today. So first talk is on no touch technique, but different, and diagnosis is by observation and growth chart. And to deliver this talk, we have none other than Dr. Y.K. Amdekar sir with us and Dr. Rajesh Chokani. And all of us, you will agree with me that whenever we observe any child for dysmorphism, we diagnose Down syndrome, we see his behavior, we diagnose as a possibility of an autism spectrum disorder. And when we plot an anthropometry on a growth chart, we know that something is wrong since the beginning. So I request, and both of them does not require any introduction. So going forward, I just request sir, both the sirs, Amdekar sir and Rajesh sir, to take over the session. Sir.
Well, thank you very much, and thank you all of you. I think Neil has already said she has started a project where each one of us is expected to use the growth chart. And we were wondering what is this growth chart is. Few months ago, my brother-in-law in US had to visit a doctor because he was not well. So I talked to him and I said, what happened? He said, I spent 3 hours going and coming, and the doctor spent 2 minutes. I said, what did he do? He said, no, he examined me without touching his hands and brain. This is exactly his word. I was examined by untouched hands and brain, because he looked at the reports and wrote something. Then we thought that, can we also do the same? Because it's an advanced country. Okay. So we thought we will also do the same, but with a difference. What difference? We will not touch with hands, but we will use the brain. And you will be amazed to know that growth chart can give you a diagnosis. And today we are going to show you how growth chart can give you a diagnosis. Of course, history, and you add on growth chart. Without touching a patient, you almost know the diagnosis. That's the power. And you want another one to a power of observation. Before touching a patient, you almost know in your mind what you are dealing with. What power of growth chart and observation. And today is going to be an interactive session. Again, it's not a talk, it's not a lecture. Each one will raise the hand, we will get the mic to you, and please feel free to opine. We will have also some audience poll so that you can pick up your option, and then we will discuss each of the options that have been there, right? With this kind of an introduction, I think, Rajesh, let's get over.
Yes, sir. So, good morning, everyone. So, let's start. What do you think a growth chart can tell us? Start. Whatever comes to your mind.
Dr. Vaman Khadilkar told me when he went for a fellowship in endocrinology to UK, he had to spend first whole week only taking the height correctly. I never knew it was so difficult that for fellowship you have to spend 1 week, 8 hours a day taking height. We don't have to do that much. But at least take the height, take the weight, if possible head circumference in a small child. And you don't have to do it. Your assistant can do it, right? But what is it important? Somebody is short, somebody is tall, somebody is thin, somebody is fat. How does it make a difference? Is it important or only for endocrinologists?
So, can it tell us anything about non-endocrinology? General well-being. What else?
It will tell about how's the growth going on, whether child is undernourished, normal growth, normal or overweight, obese.
Okay, I'll modify my question. Can it tell us anything about other diseases other than endocrinology?
Any chronic disease which is causing stunting.
Okay. Anything else?
So any kind of occult system or organ affection, mainly the renals.
Fantastic.
Hematology.
So occult diseases will be picked up better. So the first thing we realize is that growth charts can define the time of onset of a disease.
Many times the mother would say, the illnesses only last 4 days. And we don't ask the question, was he completely all right before that? If you ask, the mother said yes. You look at the growth chart, there is a faltering of weight for a month before the first symptom was reported. Straight away from acute illness to subacute chronic illness comes to your mind. What a power. Growth chart tells you the onset, duration, progress. Did we not study this first MBBS, second MBBS, first term? ODP. Growth chart can tell you, right?
Then you have so many patients, abdominal pain, last 3 years abdominal pain. First thing that comes to your mind is this a persistent disease or a recurrent disease? And that you can get from a growth chart. You can get progress or non-progressive disease. So all these things about diseases other than endocrinology, we can get from a growth chart. So now what are we really, just to super simplify it, what 3 main patterns should we always look for on a growth chart? So any thoughts on that? You're looking at weight and height. What 3 patterns?
3 patterns will be whether the weight and height are commensurate with each other.
Okay.
Or whether the weight is faltering more than the height.
Okay.
Or is the height chronically getting affected. Or as sir said, whether its onset is slightly after a few years of normal growth. So it's a different patterns you can come to.
Okay.
And
Very
growth
good.
velocity.
Fantastic. Growth velocity. Okay. So now, yeah.
It also tells us about the nutritional status of the child.
Absolutely, absolutely. So let's start remembering the first pattern, significant affection of weight without affection of length or height. So only weight is affected, no affection of length or height. What does this mean? Acute acute affection of growth, but severe, significant. So then what does it mean? It means a acute serious disease. So examples are a suddenly worsening infection like a MDR TB or a cystic fibrosis, immune deficiency, some inborn error of metabolism. So in a short time, weight is going down, height is yet to be affected, but weight is going down significantly. So this is one pattern that we have to pick up. This is a big, serious disease, right? What is the second pattern that we have to pick up? Both are affected. Weight affected, height also affected. But weight is affected more than the height. This is the classic pattern of chronic malnutrition, right? Now, can someone tell me why weight is affected more than the height?
So the body will give priority to growth of height because weight can grow throughout the life. Height will grow to some extent.
Okay. Something to add to her?
It is more volatile and dynamic parameter.
Okay.
Acute fat loss causes the weight loss.
Okay.
Weight is related to the recent intake. When a child is having a chronic disease, if the intake goes down, the weight will be affected more, and height takes some time to get affected.
Okay.
When
Yeah, I think
nutrition starts suffering, the nature says, what can be the first that could be sacrificed? And that is the weight. Okay, because the height can grow only up to the puberty, but the weight can be gained even thereafter. So this is the nature's way of budgeting. But then even after some time, the nutrition is faltering further. Then it says, spare the brain. Okay, and let the height go down. See how nature works so well. And it gives us an idea clearly how the growth chart helps. It tells you the duration of the problem. It tells you the progression of the problem. So good information. Only if we think, right? And I think that's what we are trying to make it.
so. This is the pattern of chronic malnutrition When we see this in a very young child, early infancy, first year, second year, it is often primarily nutritional, right? It may be otherwise also. But when you see the same pattern in older children, we call it secondary malnutrition. What does this mean? What is the word secondary malnutrition mean? It means that the problem is not due to less food or not because of primarily food not available, etc., but it is secondary to a disease process. So you will see the same pattern of weight and height both affected, weight more affected than height, but when you see it in a little older child, think that there is a disease behind this rather than just lack of food. Now, of course, these are not etched in stone, but primarily younger child, primary malnutrition, older child, secondary to disease. And the last is faltering length or height without affection of weight or much more than the weight. So this can only happen when there is a primarily height problem, which is your classic endocrine short stature or your skeletal dysplasias or your chromosomal abnormalities or whatever. So these are the children where height is more affected than the weight. So these three patterns we should never miss on a growth chart, right? Besides the fine tuning which we will see now. And one or two other lessons, recurrent diseases never have growth faltering. So ulta, if a child does not have growth faltering, however long are his or her complaints, they are not a persistent disease, they are recurrent diseases. So recurrent viral illnesses, asthma, do not have growth faltering. And this is what we can use. Parents come and tell us, हर बार बुखार घड़ी घड़ी बुखार आपके पास ही आते हैं डॉक्टर साहब ये क्या हो रहा है you look at the growth chart and you tell them that the child is absolutely fine. Of course, you follow the head circumference in the first 2 years of life, and this is one of the most important lessons that we feel, that chronic complaints with normal growth parameters almost rules out a significant disease. This is a golden rule that we must follow, because there will be many children who will come to us with chronic complaints, and if this is normal, we can put a break to our investigations, right?
Friends, you are convinced how growth chart is so useful. And it is most useful for those who have a large practice and only 5 minutes per patient. Because you can make it out in 2 minutes. Person like me can spend a lot of time. For me, growth chart may not be important. I still use it. So don't give an excuse, I have no time. If you have no time, use the growth chart. If you have no time, observe. Forget the rest. Even if you don't examine a patient, that's fine. If you don't take a good history, that's fine. Because the power of growth chart. Now, how many of you have a growth chart for your patients? Large number. And how many chart it? And how many explain the parents what it means? So there is a lot to do, right? And I think Neil has, and the whole team has decided to put this project on. And I think in the next few months, before the next IAP conference comes, let us have a prize for a city which uses growth chart for every patient. I think that's the aim of Mumbai IAP, and we must support them for that. The whole nation will know, all IAP will know that this is very, very important. Everybody knows. But excuses. I've told you, if you have no time, use the growth charts. And if you have time, use it many times. Okay, that's fine. Yeah.
Significant faltering of weight over long duration time, the point well taken. But is it the onset, how it starts? That means in chronic malnutrition or diseases, the weight loss will start earlier if you have past record, followed by height chart. Whereas in endocrinal problem, weight and height will stop dropping both together. Would that be a useful thing?
Absolutely. So, as I said, the fineries of each pattern will come later, but this is a broad generalization which we should not miss, right?
And I think for adults also, explain the parents also. Why do we have a bathroom scale? We have to weigh every week naked. And as an adult, if you are down by half a kilo or 1 kilo, you might find, oh, I had a lot of work. Next week you are further down. Go to your doctor and say, find out what is wrong with me. Then only you can diagnose serious illnesses in the first week of onset. I tell every parent that you must weigh. We talk about bathroom scale, but either we don't use it in the bathroom or you never use it. How important it is, right? For all of us also, right?
And sir, one thing more to add, how it is to be done. I think we need to teach all our staff. Every time the staff changes, that way of and technique of taking the weight and height is different with each and every staff. A standardized method or maybe a video or something like that which we can teach to our staff how to take weight and height.
I think standardization is not important for me. We have not been doing it at all. What standard? Okay. The experts or an academicians ask me, which graph do you follow? I said, at least follow some graph. Something going up is enough. Yes, you are right. Now, no weighing machines are standardized. Who bothers? I have the same machine which gives a faulty reading, but regularly faulty reading. So I get a trend, finish. Okay. Here lies the difference between academicians who is theoretician and a people like us who are in practice. Okay. When we started the fever project, okay, everybody said, but which thermometer? I said, any thermometer. Use the same thermometer, that's it. So I understand. Theoretically, yes. Practically, absolutely not necessary. Start doing it. Once we all do it, the hell will decide which standard to follow. But just now the standard is follow it. Right? Yeah.
Okay. So now let's move on. So
Can I
we
have
have
one question, sir?
yes, yes.
Suppose there's a chronic malnutrition, and after certain time, even height also reduces. Now, I will think other way around. Suppose there's a obesity, and is going on very healthy way, nicely. I mean, all parents, they are very happy about.
Yeah.
You
अच्छे
feel
खाते
that-
पीते घर का है.
But you feel that even height will go up?
We'll come to all that, sir. We have case scenarios for that.
Thank you, sir.
Okay. So we have 3 2-year-old children who presented with poor weight gain and recurrent illnesses. And the recurrent illnesses are in the form of diarrhea and respiratory infections. Okay? And on examination, except for the fact that they have grown poorly, they don't have any other identifiable abnormality. So what are your thoughts? What are the different possibilities in your mind? Just randomly.
Recurrent infection in an infant or a young
Poor
toddler.
growth and recurrent illnesses. Any thoughts?
Of course, immune deficiency.
Immunodeficiency, fantastic.
CF,
Cystic fibrosis. Anything else?
fine.
Can be anemia. Anything else?
Recurrent UTI.
TB? Yeah,
Of
it can
course.
be TB. HIV? Okay?
So investigate all this, no, Rajesh? Where is
Huh?
the problem?
Yeah. So about 10-15,000 worth of investigations. Agreed? फिगर याद रखना, बाद में important है ये फिगर कि कितने का investigations बचाया.
So now we will diagnose it only on growth chart. Okay? Let's show the first growth chart.
Okay. So out of these 3 children, we are taking the first child. Now this is the weight and this is the height of the child.
What about previous ones?
Sir, what?
No, because previous ones were never taken, no. But we will try even with one reading. But we don't want one reading only. But even one reading is possible. Let's opine.
So
what
what's your
this-
thought process on this weight and this height for a 2-year-old child today?
We want to know origin, duration, and progress with these 2 points. Difficult.
Very
right?
good. So the first thing that ma'am has done is picked up the pattern that weight and height both are affected and weight is affected more than the height. That pattern we have picked up. Fantastic.
So
Now,
it's some chronic problem. Okay. Now we will chart
now,
the previous
sir,
one.
no, sir, your question. So now, sir's question. Now you have to do one step better. So now you have to tell us the onset of this disease based on only these 2 points. So now think and tell us when could this problem have started only based on this point. Everyone wants previous points.
See, he is 2-year-old. Did it start in the first year or second year?
Early infancy.
Fine. So first year. And in first year, she said early infancy. Correct? So you got that this problem started in infancy sometime. How early we won't know. Okay. See, already we have picked up.
So
And
there
the
is
duration almost 18 months. Say 6 months it started, 18 months. Onset at about 6 months. Okay, maybe 4 months, maybe 8 months. Duration 18 months. Progress slow. Yes, it has not gone down. Got origin, duration, progress, even with 1 point. Now let's.
So there is a science behind this, okay? So the question we asked is, when do you think this has started? Look at the height. What is the height of this child? The pointer nahi hai na? Okay. So this is, the height is roughly 78 centimeters at 2 years, right? Now, as a common sense, when did this height start getting affected is the question. So we all know that first weight gets affected, then if the problem continues, then height gets affected. So arbitrarily, let's say height starts getting affected 4 to 6 months after the weight started getting affected. This is one point. Now for him to be 78 at 2 years instead of 87, it couldn't be that he stopped at 1 year, 2 months, button switched off and height stopped growing. Agreed? The height started slowing. So in the second year, instead of the normal 12 centimeters, he must have grown 8 or 9 or 7 or whatever. It started slowing. So that means the thing started when the height was roughly 70. So which is somewhere between 6 to 9 or 6 to 9 months. This is the way you roughly try to judge when this started, right? So that is possible even with these single readings, to go back and see when it started. Now we'll get some of the previous readings, we'll fish them out. So we fished out the previous readings. This was a full-term baby with a good weight at birth. These are some of the readings we got, and this is the graph we got. So now tell us, looking at the weight graph, when did the problem start?
Clear, right about 6 months or whatever. Okay. And it's slowly going down. So chronic problem slowly growing, starting at 6 months, in a normal child was going up. What's the commonest cause?
So something which started at 6 months, ask one question and you get your diagnosis.
Yeah. Faulty feeding.
Complementary
fine.
feeding.
No investigation required, counseling. What a power, right?
Kitna bachaya?
Yeah. And we have seen many of these
15,000.
children investigated.
10% cut. Okay? You are allowed to charge 10% cut to the patient.
Yeah.
Okay? Okay. Now, sir asked some time back why no height readings plotted. Unfortunately, we don't require the height to prescribe antibiotics. So nobody takes heights.
In
So
fact,
there was no older height readings.
Every baby who comes to our clinic, we all have a joint clinic, goes out with a growth chart. Now many of them go somewhere far off And suddenly they may appear after 2, 3 years. And I said, have you got a growth chart? He said, yes, of course. And I said, it's not marked. Then the husband and wife look at each other, and the husband says, sir, don't feel bad. But my pediatrician said, those who have no much practice and lot of time, keep on doing it.
And we'll come back to this patient after 3 cases. This patient which sir just mentioned. Okay, so this is done. Faulty complementary feeding. Okay. Now let's take the second child out of our 3 children who had recurrent illnesses. Yeah.
Will faulty feeding itself affect the height to this extent, going below third centile?
Because Kamlakar, he is quite undernourished and he's started at 6 months and he is now 2 years. So this is like severe acute malnutrition.
This is crossing the centile to less than 3 centiles.
Of course.
Is there something else apart from only faulty feeding?
So it depends on at what age it started. If it starts at as early as 6 months, the amount of growth in the first year is tremendous, and of course part of it in the second half. So if it is severe acute malnutrition starting at 6 months, by 2 years height will be affected. Height is 78, which is under the third centile. Absolutely, it will be affected. There's
Not
no
convincing, but yeah, okay.
Kamlakar, most important is, we thought of many possibilities before seeing the child. Nothing would have gone so slowly. Everything would have gone down. Good enough to say no investigation required. Okay. And anything that starts at 6 months and goes down slowly cannot be anything that we first talk of CF and immune deficiency and all that. It's all out. So how easy it is to make out whether you need any further investigations or not. And I think we are trying to convince you that growth chart has helped me tremendously. When I see patient for second opinion, with a growth chart I know where the problem lies. Okay. And we will convince you with multiple such patients, right?
Okay, so we pick up the second child out of those 3 children. This is the weight and this is the height. So now what are your thoughts on today's readings? Which pattern? So when will both be equally affected? Think of a situation when both will be equally affected. In which disease?
Rajesh here.
So something very long standing, chronic, or something which is not
Something which is very acute. Time to affect the growth. Something which is very acute.
In acute height won't be affected, sir. In acute height won't be affected.
See, even
Child may just be a stunted small child. It's not a progressive organic or systemic problem.
So that's the whole point that we want to make. We just said a while back that any disease will first affect the weight, continue to affect the weight for a while, then if disease goes on, height will be affected. So for disease, there is no situation where weight and height can be affected equally, which means both are equally unaffected. We tend to look at it as both equally affected, but both are equally unaffected.
theoretically, if you look at 7 or 8-year-old child who has been suffering from 1 or 2 years of age, he may end up almost symmetrically poor height and weight, but it will be way down. Okay, it will be not just at the border, it will be way down. And even that is a theoretical possibility. And I recall occasionally seeing an 8-year-old, weight and height both tremendously affected, because there is nothing more to lose now. Okay, but he is so down, he is not minus 3 SD, minus several SDs. This is a borderline one. So what does that mean now?
If at all
She
there is a
said like
problem-
slowly growing, yes.
No, if at all problem,
Borderline.
it's an acute problem, not.
Yeah, so what Sudhir is trying to say is that suppose his height was genetically that lower limit of normal and his weight was better a month back and has dropped to this level, it's an acute problem. That's an exception. But as a general rule, first lesson is This cannot be due to disease. So you are right, you need earlier readings.
And weight for height normal, mostly the person is normal.
And the earlier readings were fished out, and this is the weight graph. So now what do you think? Constitutional, right? Normal child.
No, but
So
Rajesh, why is he getting sick?
Come on.
He's a normal child, no?
Why recurrent respiratory illnesses?
Parents want to know, okay, he's normal, but does normal child get sickness again and again?
They do get it in the first 2 years of life.
Sir, they get in the first year of life also.
Could be a routine virals or asthma, as what you told me. These are recurrent illnesses, what he may be getting.
So actually, this mother started going to school antenatally. I mean, first year, so you see many mother and toddler or mother and baby going to school. Na? We have 6-month-old babies going to school nowadays. This mother started antenatally. That's why cough and cold. Okay? So normal child. Now let's look at the third child. This child's weight and height is this. Now, what are your comments?
That upper point is the weight, though it has come in the height chart.
What are your thoughts on this now?
Where is the origin? Duration we know. If we guess origin and progress.
So this is a chronic, severe, progressive illness.
So how is it slightly different from the first child that we discussed? So what is different and what does it tell you?
Sir, the readings are much proportionately bad, severe compared to the
So what
first.
does it tell you?
So this disease has been there for some time, quite early and quite severe, progressive, which is
So
giving
the
you this-
height is worse than that first case, telling you that the onset is even earlier. So you've already decided that based on these single readings that the onset is much earlier. Now look at the weight. Weight at birth was 3 kg. These are the earlier readings fished out, and this is the graph. So now tell us, when did this disease start?
See, by 2.5 months, he looked okay. Probably started faltering down thereafter. By 6 months, had already come down.
So 2 or 3 months literally it has started going down. And one question at that time, what was the feeding? The feeding was exclusive, adequate breastfeeding. What does this tell you? So this is on exclusive adequate breastfeeding. So this is a catabolic disease. So this child is a serious disease. It could be anything of that first list that we were talking of. It could be immunodeficiency, cystic fibrosis, whatever. So this is a serious disease that needs investigation. So going back to the 3 children who came with poor weight gain, first one needed just advice on complementary feeding. Second one needed counseling and no medications, no action to be taken. And only the third one needs investigations and treatment, which would not be the case if you would have not done a growth chart. All 3 of them would have gone through 15,000 worth of investigations and then come to this conclusion. So that's the message that we want to give, right? Now coming to the scenario 2. So a 8-year-old girl came for a routine visit and was found to weigh 43 kg. Are you worried? अरे अच्छे खाते पीते घर की है, क्या प्रॉब्लम है?
Why you are worried? Sir, पहले से ही इसका weight अच्छा है. Where is the worry?
Okay, so what do you want next? TSH. Okay. So this is the height. So now what? What investigations? Come on. So everyone agrees that this is nutritional, exogenous, whatever word you want to use it. This is called malnutrition. MALL.
But Rajesh, what's the use? What can we do? Can we do anything?
So,
We need to counsel for lifestyle
I
modification.
know. When you counsel, nobody listens to us. Well, I think Bombay branch is trying to counsel everybody use growth chart. अरे वो तो बात करते रहते हैं, वो तो अभी secretary हो गई ना, इसलिए बात करते हैं. Okay, yeah. So you're right. The question is, when did this start?
So-
And the only chance of improvement was at that point. And look at the earlier chart.
so this height you are saying is exogenous. And if the height was this, then endocrine.
Endocrine.
Okay?
How simple.
So tall and obese, short and obese. Everyone is clear on that? Okay. Now coming to sir's question, when did this start? So we fished out some readings and picked up this graph. So now the question is that this child was coming to us only. Correct? This child was coming to us, but we were not plotting growth charts. I am giving a scenario. Us means not us as in not me, but what I am trying to say is you will find that this child, when you start plotting at 43 kg, you realize के काश मैंने पहले के भी किए होते. So the counseling works if you do it at that 4-year thing more than the counseling working at 8 years when she is already 43 kg. Right? And now I come back to that patient which came to sir saying के
And I
जिसको
recall
time नहीं.
a mother who brought a child after 5-6 years. I said, sir, do you remember us? I said, yes, I do. No, we used to come to you in the first 2 years because he was very thin. Then we left you. And then he started gaining weight. So I said, why do you come again? Now he is too much overweight. Okay. I said, what happened in between? In between we were happy. Now we are again. So you are expert in keeping babies thin. So we are here. Okay. But first they said, ever since we left you, he started gaining weight. Okay. Yeah. So I think that is important, right? And today we know syndrome X, etc. All those thin fellows, if they don't remain thin, they are in trouble. So what is the final thing? Those who are thin always remain thin. Those who are a little better weight don't go beyond that. But those who are thin never become fat. If possible, those who are fat can become a little thin. Right? So that's the message.
So we all know that the risk of obesity is more in that 5 to 8 year window. And after 5, we are not likely to meet those children again because of vaccines also mostly getting over. So our counseling has to be much before that, and it is likely to work better. So if we keep looking at this graph every time and it starts going up, you start counseling right from that time about food habits and outdoor activity and things
And
like
I think
that.
we pediatricians get a lot of opportunities. And now we have an HPV also coming. So you can go well up to adolescence and puberty. Okay, no excuse. Every time a growth chart.
Okay. So now we start with some audience polls also. So you have a voting pad on your tables. So all of you can use it. The method is first we will read out the case. We will read out the options. Then when I say that after the music starts, you can start voting. So wait for a second or two for the music to start and then you start voting. I think I have said this earlier also. Take care not to take this remote like thing home because it doesn't work on our spouses. And second is that after voting, everybody can claim that they voted for the right answer because nobody knows who voted for what, right? Okay. Now, I'll first put the points on this graph. Okay. A 6-year-old
Can you
girl
all
has
see
been...
that? I think this cannot be moved, so some of you might have to come on this side if possible. Even come right on the first rows. Please come on the first rows because you may not be able to see the graph. Okay? And she tried to get this, but that cannot be done so easily. Fine. There's no problem. We can shift a little, right? Yeah, please Please occupy these seats. Please occupy these seats.
Okay, so a 6-year-old girl has been brought because she's among the shortest in class. Some past records were fished out, and this is her growth chart that was possible to create today. Mid-parental height is 164. The most likely possibility is familial short stature, constitutional delay of growth and puberty, early growth hormone deficiency, or hypothyroidism. And you can vote after the music starts. Okay. So largely the house is divided between the first two options, and some of you still feel that it could be endocrine. So now the way we discuss all these options is either you can argue against the option which you don't think is right and say why that option is wrong, criticize that option, or you can defend your option, whatever way you want to participate. And please, again, I'll repeat, this is just an interesting way of learning. Don't worry about making mistakes or saying wrong things. We all are in the same boat. Sir always says every Thursday we go to Sion to teach, and every Thursday something weird comes up in that case, which we wouldn't definitely have predicted or analyzed. So we are always learning. So don't worry about being wrong. So come on, who wants to take the lead and defend your answer or criticize somebody else's answer? Criticize means why that is wrong.
Yeah, here, Rajesh, here.
Sir, I have marked constitutional delay of growth and puberty. It's not familial short stature because the mid-parental height is 164. So it cannot be due to a familial short stature. Also, the weight and height are equally affected. So I have marked constitutional delay.
Okay, why is it not early growth hormone deficiency?
Sir, because in hypothyroidism and early growth hormone, this comes under endocrine hypothyroidism. The height, the weight won't be affected in growth hormone deficiency, sir.
Okay. Okay.
Because it's the endocrine.
Suppose he's a thin child. Okay, very good. You're there. Yeah.
Good. Suppose if it was hypothyroidism, then actually there would be a weight gain.
Very good.
Yeah.
So hypothyroidism would have been a little plumper. So hypothyroidism is 100% out. Then?
And even in early, growth hormone deficiency, in fact, the height will be affected. If both are affected, they both are on the third percentile, if I can see. And even if the weight is affected, the height will be affected much more than the weight.
Okay. Yeah. I heard something. Yeah, what do you mean by growth velocity? Very good.
Gain between two assessment points is normal and it is being maintained.
So that is why not growth hormone deficiency also, because you have 3 different points at a long interval apart, and if it was growth hormone deficiency, it should have started going down. So what Praveen Mehta sir said earlier about velocity, same he also said. So that's why no, and familial no because the parents are reasonably good height, right? So this is constitutional delay. So now we have realized that even without the bone age, we have been nearly correctly able to pick this up. Again, exceptions apart, but the point is that we have picked it up without the bone age. What one clinical question helps you to pick this up? No bone age, just one clinical question.
How are the parents? How are the parents?
Very good. So either of the parent, did he or she follow the same pattern as a child? And if that is so, then you can almost be sure this is constitutional delay. Right? Okay. Okay, next scenario. So again, we have 3 6-month-old babies with breathlessness. Now we are not trying to tell everyone that stop doing other things, stop taking history, stop examining. No. The whole exercise is we pick up one area and try to make all of us remember and realize that look, this area is also so important, so useful. So we've done sessions on history where the diagnosis is only on history. We have done similar sessions for different parts. So here the focus is how much a growth chart can tell us. It's not that you're not supposed to take history or you're not supposed to examine, but for today, we will do it only on the basis of growth chart. Right?
We have been saying that history gives 80% of diagnosis. The growth chart gives almost 70%. And the observation 50%, total 200% before you touch the patient. What more do you want? We're just trying to pick up one of the areas and trying to see how good it can give us an information. Each one can give us an information. And I think we have yet not palpated a patient, not percussed, not auscultated, only inspect. And the better word than inspection is observation. You know what inspectors do in the country? They don't observe. We must observe, right? So these modules are not to get away from history, physical examination, no, very important. But you build up that. When we teach at Sion, we tell them at the end of history, tell us the weight, height, head circumference, and the physical findings of a patient expected.
Expected findings before touching the patient.
Yes, they can do it. When we guide them, they can almost tell me the weight and height likely to be without looking at the patient. That's what Dr. Udani used to do. Some of you who were there, he would ask me, what must be the weight of this child? I said, sir, without looking, he said, of course. So that power, right? We are trying to use every bit of power to enhance our bedside clinical diagnosis, right?
Okay. So the first of these 3 6-month-olds with breathlessness has come with acute onset breathlessness with no cough, and this is the growth chart. So first analyze the growth chart and then we'll come to how it can tell us the diagnosis. So what does the growth chart tell you? Normal? Everyone agrees? So that means the disease is chronic or subacute? Chronic or subacute?
Acute.
Acute. So acute disease causing breathlessness in a 6-month-old baby without cough.
And
bronchiolitis.
6-month-old healthy baby. 6-month-old healthy baby, acute onset of breathlessness. Okay.
So bronchiolitis. So sir, they answered acute bronchiolitis. Okay. Now the second baby has chronic breathlessness with mild or no cough. So at times mild cough, at times no cough. And this is the growth chart. Now first analyze the growth chart. Okay, so both are getting affected. Very good. So when both are getting affected, what is our interpretation?
Acute on chronic.
Chronic. And we said the pattern of chronic disease is both affected and weight more affected than height. Is weight more affected than height? Yes. So this is a chronic disease in a 6-month-old infant who has chronic breathlessness with mild cough. Okay. Cardiac. Anything else? Okay, so cystic fibrosis. What else? Because you have to look at when it started also. So now as Sudhir pointed out, look at when it started, look at the degree of affection by 6 months and tell me cardiac yes or no.
When did it start? When is the onset? See, at about 1.5 months, she was almost going a little up. And thereafter, by about 3 months, he seems to be faulting. So somewhere between 2 and 3 months, the problem started. So onset between 2 and 3 months.
So
What
now
is the progress?
So now a cardiac disease which has affected both weight and height by the end of 6 months, when would it start? Much earlier. So by that yardstick, this is less likely to be cardiac. Right? Okay. What else? Okay, inborn error usually will go down much worse, right? And would again start earlier. Okay? Okay, GERD, will they be breathless?
Recurrent pneumonias.
So I think the onset is around 2 months, the progress 4 months, but a slowly going down, not fast. CF, cardiac would have just gone down fast. Okay. So now we have to find out a slowly worsening breathlessness. Slowly worsening breathlessness.
Very good. So now we have two very good options. One is interstitial lung disease, chronic interstitial lung disease, and renal tubular acidosis. Both are very close to each other. There will be a small difference according to Sir and us, which we will tell you. So this one is chronic interstitial lung disease. And now look at the third one. Third one is chronic breathlessness with no cough. And tell me what is the difference between this third one and the second one which we just did. Weight is more affected and maybe started a little earlier. So this is the small difference between renal tubular acidosis and chronic interstitial lung disease that we think, of course, clinically, mild cough favors chronic interstitial lung disease and no cough favors renal tubular acidosis. Right? Okay.
And look at from 3 to 6 months in this, there is a sudden going down. In the previous one, it was going a bit slow. We are not trying to say just by that we can make out. We already said 2 possibilities. But further, of course, when you looked at the patient, observe an RTA would be looking sick. A chronic interstitial lung disease may not look sick, but may be uncomfortable. So small differences can make observation. Add to that, you will find a difference.
There's another one. Yes, but then the complaints will be and fever. At this age, of course, yeah.
And even an RTA, as compared to chronic interstitial lung, RTA is a rather acute illness at that age. Okay, child comes with an acute onset of breathlessness, not even chronic. Chronic comes up a little later in old age. So small difference, but that's not important. We are not giving a final diagnosis. We are just trying to make. And if you can make out one of the 2 only in a growth chart, that's big enough, that's good enough.
Okay. 3 2-year, 3-month-old children with edema. Okay? Happy child. This is the growth chart. First analyze the growth chart. Weight has increased. Sudden or gradual? Sudden. So 2 year, 3 months with edema, happy child, sudden increase in weight. Nephrotic syndrome. Fantastic.
Happy child and happy mother. Going
Okay.
Yeah.
Second 2 year, 3-month-old with edema. This is the growth chart. So again, weight increase is sudden or gradual. Now, I want to make something clear here that when it is acute or short, remember that I saw this child last at 2 years And then I saw this child today at 2 year 3 months. So that graph which seems to say that that weight went up over 3 months need not be over 3 months. It is from the last time I saw, right? So this is an acutely sick child. So what do you think?
Nephrotic was happy. He is acutely sick.
Acutely sick child with edema, dengue, capillary leak.
Capillary leak.
Okay? Okay. And this is the third one, 2 year 3 month with edema, chronically sick.
Origin?
He looks unwell. Okay? Okay. Could be cardiac, chronic liver failure, renal. Okay? Okay. Anything else? Kwashiorkor. Yeah, very good. So this is chronic liver disease, chronic heart disease, PEM, anything. So again, what is the growth chart showing? Where is the onset? First of all, what is affected? Weight and height both affected, weight more affected than height. Onset? 3 to 6 months of age. Correct? Weight has started going down between 3 to 6 months of age. So again, whether it's nutritional or whether it is secondary to a disease process. So both possibilities are there. Right? Okay. Again, an audience poll. So this 4.5-year-old boy has come with recurrent wheezing episodes in spite of being on inhaled corticosteroids. The probable diagnosis is 1, steroid toxicity. Actually, I forgot to add. So poorly controlled with steroid toxicity. Second, partially controlled bronchial asthma. Third, cystic fibrosis. Fourth, bronchomalacia. And your voting will start after the music. Okay, so majority of the house feels that it's cystic fibrosis, but some also feel it could be partially controlled asthma. So let's fight. Fight, healthy fight. Chalo, someone to defend one or the other.
Or someone to negate partially treated bronchial asthma. Doesn't matter, you may not have opted for it, but you try to convince us it's not.
Is the cystic fibrosis?
Sorry, who's speaking?
Yeah. It could be cystic fibrosis based on growth chart. It start from the very early and both growth and height is affected equally. And being sometimes recurrent cough, mildly misguided diagnosis as a asthma, and despite of recurrent steroids, still symptoms are not improving. There might be some problem with mucus clearance or any other respiratory infection.
Okay, so good. So you are saying both weight and height are affected, right? And when did it start? When did weight start getting affected?
After the 6 months as well.
This is a chart which is showing from 2 years. First 2 years ka growth hai hi nahi.
Okay.
So when did it start getting affected? Before 2. So weight has started getting affected before 2 only. Height has started getting affected later. Okay, so you tell us, why is this not partially controlled asthma?
If inhaled steroid are given properly, then it might not be possible as a partial steroid because parents might be motivated.
Okay.
A partially treated bronchial asthma will not have such severe growth faltering. Weight especially, and even the height is faltered to this extent, it will not be seen.
Could it be steroid toxicity and that's why the height has gone down?
In case weight might be increased.
Inhaled, it is unlikely.
And of course, weight will not be affected. So for multiple reasons, the answer is cystic fibrosis and none of the others, right? Now here we must remember that cystic fibrosis has a wide spectrum. So you would have the milder variants who would, otherwise the severe variants would be very bad even in the first and second year of life itself and would present with pneumonias, fever, whatever. But some who go on for longer may come like this as asthma mimics. Okay? Now, 4 one-year-old children with developmental delay. Okay? And we will only look at the growth chart. First, we will interpret the growth chart and give a probable diagnosis. The diagnosis, of course, guess, but you have to interpret the growth chart. So this is the first growth chart. It's a one-year-old child with developmental delay. Somebody interpret the growth chart and then we'll collectively guess.
So height is in the range, growing properly. The weight has gone up. So this has to be definitely a non-progressive developmental delay, most probably a static developmental delay. And with the weight going up and height going a little lower down, it could be some kind of a chromosomal anomaly, if at all.
Okay. Okay. Anyone to add to that? Tu नको रे, tu faculty आहे इकडे. Anyone to add to that?
It's a static, basically it's a static developmental delay, and the weight has gone up because the child has been non-mobile, non-ambulatory. That could be chromosomal, could be any kind of a perinatal insult.
Okay. So, yeah. Okay. So, let me ask you 2 questions. One, how severe is the weight gain? Chota mota? Very severe. So very severe means khali just because the child is non-mobile or is being fed well, we won't give rise to very severe weight
This is
gain.
obesity with delayed development with a normal head circumference. Okay. Hypothyroid doesn't gain weight so much.
Sir, don't
it may
give
be
them.
normal or a little above normal. And therefore, this is a syndromic obesity with delayed development. What you said, chromosomal, yes, but syndromic.
So any chromosomal anomaly which is syndromic with obesity and mental retardation, it could be any one of them. Why is it not a birth injury? Head circumference is normal. Okay? Okay. This is the second child with developmental delay. चलो जोर से birth injury, so cerebral palsy. So why not prenatal? Okay, he is saying good weight. I want a stronger reason why not prenatal.
Birth head circumference is normal.
Excellent. Birth head circumference is normal.
See, we are all charged now. Okay, yeah, see how correctly, quickly answers are coming out, right? Yeah.
Okay. Third child with developmental delay. Interpret the growth chart. Weight is affected. More than height, both are affected. Weight is affected thoda ke bahut. So,
and the
massive affection
normal.
Massive affection of weight in a developmentally delayed child. Metabolic disorders or neurodegenerative disorders. Excellent. And this is the fourth child with 1 year old with developmental delay. Interpret the growth chart.
Head circumference is suddenly increasing.
Means what? Thoughts. Hydrocephalus. Congenital or acquired? Acquired. So which acquired hydrocephalus is associated with developmental delay?
And a
Tuberculosis. TBM, tuberculosis. Anything on the growth chart which favors that other than the head circumference? Weight is dropping recently. Fantastic. So this is TBM with hydrocephalus.
So you got syndromic, you got CP, you got neurodegenerative, you got acquired TBM. 95% of all developmental delayed covered only by growth chart. Right? So again, so much of importance.
Okay. 3 4-year-old children with severe anemia. Okay, first growth chart. Interpret the growth chart. Weight normal, height affected. So which severe anemia has weight normal and height affected? Which category of anemia? So category of anemia means we talk of deficiency anemias, we talk of hemolytic anemias, and we talk of bone marrow problems. So which category has weight okay and height affected?
Hemolytic.
Hemolytic.
Chronic hemolytic, most common thalassemia.
So this is chronic hemolytic anemia. Okay? Second child with severe anemia. First interpret the growth chart. Both are normal. And this child has severe anemia. So it might be acute anemia. So now DD of acute severe anemia. Okay, so bone marrow problems or acute blood loss, acute hemolysis. So this is acute anemia, either acute leukemia or acute hemolysis. Okay? And this one. A slight difference from the previous one. What is the difference?
Weight has started to falter.
So, but is it still within the normal range? Okay. So what would you think of in terms of severe anemia, which category? Do you think this is hemolytic anemia? No, because height is okay. So nutritional. So that's what? This is deficiency anemia, nutritional anemia. Right? So 3 children with severe anemia you have diagnosed only on the growth chart. Okay, now audience poll. So this 4-year-old boy came with history of rapid weight gain. His parents are obese and of average height. The most probable diagnosis is, and the options are from the growth chart, the diagnosis. Exogenous, that is nutritional obesity, congenital hypothyroidism, adrenal tumor, and monogenic obesity. And your voting will start after the music. Okay. Tough fight between 3. Exogenous, adrenal tumor, and monogenic obesity. So let's argue, discuss. So what do you think? First analyze the growth chart. What's happening on the growth chart? Some new people. I think everyone is happy now to participate. So some new, yeah, please.
So weight is increased.
Okay.
At the time of birth, initially it is gradually increasing.
So when did the weight increase start?
3 months.
Okay, so at 3 years.
And
so
height is?
One sec. So till 3 years, what does the weight chart show?
It is, it is in a percentile between below 50, I think.
So it is normal. Following the curves till 3 years.
Yeah, after that it is gradually increasing.
Okay.
And by the age of 4 years, it is come into overweight, I think.
So how much is the weight gain in this 1 year, roughly?
It is 5 kg.
5 or 6
6
kg.
kg weight
So
gain is there.
6 kg in a span of 1 year.
Yes.
Which option does it rule out? At the age of 3 to 4 years.
Okay.
Anyone?
Not congenital.
So why is congenital hypothyroidism not the answer? Give me reasons.
It has happened at 3 years of age.
Okay, so one is the weight gain has started later. Second?
The height has faltered little later.
Okay, the height has faltered much later. So therefore, that is out. And in congenital hypothyroidism, you don't have so much sudden increase in weight gain. So that is out.
May the height should have been more.
Very good. So exogenous obesity, the height shouldn't have fallen. It should have actually gone up. So therefore, exogenous is out. So now the fight is between monogenic obesity versus adrenal tumor. So now,
Parents are obese, so all cannot have adrenal tumors.
okay. So but what is, so any other points for or against? Height has fallen. So that would, in monogenic obesity, there is no reason for height to fall. Fantastic. So the final diagnosis is Cushing's due to adrenal tumor. Right? Everyone agrees? Okay, fantastic. Scenario 10. 3 1-year-old children with rickets. Okay? This is the first growth chart. Analyze the growth chart. Chalo, someone from this side. Just tell us what have you seen on the growth chart.
There's a sharp decline in the height, whereas the weight is still within the normal percentiles.
So weight is normal and height, there is a drastic affection of height by 1 year of age. So which rickets has a drastic affection of height? So renal rickets, is the weight chart commensurate with renal rickets?
The common deficiency rickets is a disease of growing child. Okay. The height is going down from very early in life. Okay. And the weight has not been affected.
So anything that looks like rickets?
It may not be rickets at all, but looks like rickets.
Hypophosphatemic rickets can have severe involvement of the height.
But not so much. I would say by 1 year going down so bad is...
Skeletal dysplasias.
So something like a bony or a cartilage abnormality. So this is chondrodystrophy, which looks like rickets. Okay? Where you get a severe affection of the height. Now this is the second growth chart. What is happening? What is the growth chart showing? Normal. Normal में कुछ और normal, something which is super normal. What is the weight chart showing?
Huh? 6 months going up and thereafter steadying, not going down, steadying.
So this is known as the breastfeeding hump. You see this hump on many growth charts of babies who are being exclusively breastfed. It's just good nutrition, that's all. So this is a very nicely nourished baby. And what is happening to the height? Is anything happening? Okay. So it's a marginal drop, if at all. So this is deficiency rickets. Right? Deficiency rickets in a very well breastfed baby. And this is the third child with rickets. Come on. Analyze the growth chart. Height and weight both are affected. Thoda affected, lot affected. What is lot affected? Both are lot affected. So,
CRF is possible.
renal. So, this is renal. So, RTA with rickets. Okay. Now, audience poll. A 5-year-old boy has hepatosplenomegaly and this is his growth chart. We have only these two informations. Okay. I am not giving any history, no other examination. Based on only this information, what is the probable diagnosis from these options? Option 1, chronic liver disease. Option 2, congenital hepatic fibrosis. 3, beta thalassemia. 4, typhoid. And you start voting after the music. Okay. Why beta thalassemia? Come on, someone should justify.
What has happened to the weight? Gone up. So just beta thalassemia will have a weight gain? Or what?
No, so the weight is maintained, but the height has decreased.
Okay.
So, and if it was a liver disease, then the both will have decreased.
Very good. And what happens in congenital
And plus the
hepatic
child has got
fibrosis?
plus the child has hepatosplenomegaly.
Huh.
If suppose we think it's a congenital hepatic fibrosis or a congenital liver disease, the probability of having splenomegaly is less. Rather
Okay.
than beta thalassemia where you will have both hepatic as well as spleen.
Okay.
So the diagnosis goes in favor of beta thalassemia.
Okay. Very good. Excellent. So the point is in chronic liver disease, both weight and height would be affected. Congenital hepatic fibrosis to a point will have only hepatosplenomegaly and no affection of growth till a little later in life when the secondary effects start coming in. And therefore this is height affected, weight not affected. So this is hemolytic anemia which we just saw. So that's why beta thalassemia, right? Okay. 3-4-year-old children with ascites. Okay. First 4-year-old child with ascites and this is the growth chart. First analyze the growth chart. Normal. Okay. So a normal growth chart, a child who is growth wise normal has ascites. So what could it be? One is acute ascites. Anything else? What could it be? So which are the causes of acute ascites? Okay, nephrotic syndrome. So in nephrotic syndrome, what will happen to the weight chart? It will increase. It has not increased. So acute ascites due to nephrotic syndrome is out. Dengue. We just saw a child with dengue also. Weight would increase. Anything else? Chiari. Okay. Okay, we'll discuss that. And cardiac. Why not cardiac from this growth chart? A cardiac who has ascites is in failure. Failure for a certain length of time. So weight chart would have gone down. Some infectivity. So actually this was just a large cyst in the abdomen which looks like ascites but is not ascites. The point, the interpretation is that this is a normal child, absolutely normal growth, everything. So it is a non-infective, non-whatever problem. Okay. This is the second growth chart. What do you think? Okay. Difference from the earlier one?
So that means in the previous chart, that's very interesting. Can you rule out ascites just on the chart, saying that because this child's growth is normal, the previous child, it's unlikely to be ascites at all because we would have expected weight gain. Is that what you're saying? No.
No. What I meant is that in acute situations which actually contribute to weight gain, like acute dengue with capillary leak or whatever, we meant that the weight today would have been a little higher. So that those are ruled out. Chronic cardiac, as we said, is ruled out for weight should have gone down. So we are not saying that this growth chart tells you that this is not ascites. What we are saying is we started by saying children with ascites with a normal growth chart. So we have to start thinking, okay, if growth chart is normal, that means either the problem is acute. In acute, we sort of realize, tick mark those. Or then is it something which is benign and harmless, which is not affecting the growth of the child? That's all. You can't pick up a cyst based on that. Sorry. So answers out. This was tuberculous ascites. So the only difference is that the weight of this child is a little on the lower side. I mean, he is normally nourished, but on the lower side. That's the only difference. And this is the third growth chart. What do you think? Both are affected. Since when? What is more affected? So weight affected from? Started from 2.5 years, going down gradually. Height is also started getting affected from 2. So what do you think? Chronic liver disease. So this is chronic liver disease with ascites, right? Okay.
I think cyst in the abdomen reminds me at JJ, an intern in my unit wanted to always find one patient to be followed. And that was a cyst. And obviously my register had tapped, okay, ascites. Nobody bothers. When there is no shifting dullness, your knowledge comes handy and say, sir, too much of fluid has no shifting dullness. See, more you get information, more you are in trouble. And therefore, the fluid was normal, biochemically, cellularly. This intern said on round, sir, can I say something? I said, yes, what is it? He said, I know from undergraduate days, smiling umbilicus is a sign of ascites. But sir, this child has half smiling. What an observation. I remember the face of this intern also. Okay, he was trying to say one side accumulation is more than the other side. What a great observation. Half smiling umbilicus. Okay. He had diagnosed this straight off by that. He didn't know what half smile means. Okay. So ascites is often, a cyst is often mistaken for ascites, right?
Okay. So I think this is the last set of scenarios. So 3 1-year-old children with a seizure. This is the first growth chart. Sorry? Birth injury. So birth injury, cerebral palsy, remote symptomatic seizure. Okay? Then this is the second child with a seizure. Hydrocephalus, congenital or acquired? Acquired. So what could be the cause of the seizure?
And the head circumference going up.
Tuberculous meningitis. Okay, so tuberculous meningitis with hydrocephalus. And this is the third child with a seizure. Look at the growth chart carefully, because after that, this you are going to get a well-deserved cup of tea and coffee. We've been working so hard for last 1.5 years, hours. Take each thing properly. What's happening to the weight? Normal, with something extra? Okay. What's happening to the head?
Gradually increasing.
Gradually, slightly increasing, but well within the normal range. And what's happening to the height? Slightly decreasing. Something else in the weight, and you get your answer.
Weight, slight late faltering is there.
No. I just told you the breastfeeding hump. So now what? Head slightly large but within the normal range. Breastfeeding hump. Length slightly less than perfect. Hypocalcemia. Deficiency rickets with hypocalcemia. Okay? Thank you. So I think all of us deserve a very well-deserved cup of tea and coffee. And after that, we move to the second round. I think, yeah.
How many of you have observed dengue presenting with cellular edema and acute weight?
Cellular edema?
Capillary edema. Number one. And number two, why the hemolytic anemia with hepatosplenomegaly had an acute weight gain?
Yeah. So first of all, first question. So dengue with capillary leak weight gain is a definite, very well-known phenomenon, especially in infants. If you see in infants, and if you weigh them within those 5-6 days, and if you've picked up a weight gain, you have picked up dengue in that setting. If you start using this even in your older children, you will find a half 1 kg difference in weight, and in no acute illness there is weight gain. So this is undisputed that in dengue, once fluid starts getting collected, the weight will increase. The second,
in fact, I remember a typical infant, 8-month-old, who had a viral infection confirmed to be dengue. And I explained to her that don't worry, only observe. 4 days later, she came saying that, sir, he's a bit drowsy. And when I checked the weight, the child was half a kilo more. Good enough to say he has started a capillary leak. So weight is important in a younger one, but I recall this child, how can anybody's weight go up by half a kilo in 4 days when he's sick? So in a bigger child that won't happen, and I think that's why the capillary leak is one such situation where edema is not seen, right? Let's break for a tea.
in the second question, in the hemolytic anemia, why the weight was rising. So the point is that all charts will not follow like a military schedule. You've taken a weight after 1 year. For some reason in this year his nutrition was better, or he started eating more cheese or whatever. So that there are so many other red herrings that will come in. But the whole point is that weight normal and height low is a very select category, and with hepatosplenomegaly it only fits into hemolytic anemia. Otherwise, chronic liver disease and all that, as we discussed, have other reasons, right? Okay.
After that tea and coffee break, and ready for that another very sensitizing and inspiring dialogue that is going to follow. But after that talk on growth charts, I think we are all to see this video. Play karo.
Friends, growth chart is the progress card of health, and every child should have it being monitored till the end of the growth. Periodic growth monitoring can pick up an early deviation that could be the only clue to a hidden disease or a defect, and it gives you an early diagnosis. In day-to-day practice, the growth chart helps us to define correctly the origin of the disease, because many times the parents present with acute symptoms, but behind that could be some insignificant symptoms overlooked by the parents, and we can pick up by the growth chart a subacute or a chronic illness, though presenting apparently with an acute symptomatology. Of course, duration and progress adds to the probable etiology, and the diagnosis can be helped. The difference between a recurrent infection and a persistent infection with a recurrent symptoms like tuberculosis can be easily made out by the growth chart itself. And finally, parents are always worried about their child being thin, and a growth chart keeping up the centiles can really assure the parent that their child is quite healthy. Friends, growth chart has a very positive preventive role and also a diagnostic ability. It is so simple, it's most useful, and it is cost effective. Friends, if you are not doing it so far, please take a pledge and start doing it. After all, we all want to be rational pediatricians. Thank you.
Hello, this is Dr. Vaman Khadilkar. I'm a pediatric endocrinologist and I was instrumental in designing IIP growth charts. Like under 5 mortality speaks of health and disease of a nation, growth charts speak of health and disease in a child. In my specialty, it forms the crux of making the diagnosis as well as following the progress of patients. For example, even when there are no symptoms present except for short stature, if I see that on a growth chart child is short and obese, I know this is hypothyroidism, versus a child who is short and also has significant weight deficit, then it's chronic disease or chronic malnutrition. It also helps me in following my patients extremely well. For example, when I treat children with precocious puberty, if the rate of growth is optimal, I know my treatment is working. But if it is too fast, I know I have to increase the dose. And if it is too slow, I know I have to reduce the dose. Also, growth charts help me in diagnosing overweight and obesity early, and now with the new IIP BMI charts, I can even define the grades of obesity. I can practice pediatric endocrinology almost without endocrine test, purely based on anthropometry, growth charts, and my clinical diagnosis. So I strongly recommend all pediatricians, irrespective whether they are generalist or specialist, to start plotting on a growth chart even before they have examined the child. And I request all of you to please take height, weight, and BMI. Thank you.
Hi. Accurate tracking of growth is essential in our specialty as it helps us identify early signs of growth faltering, which can be indicative of underlying conditions such as malabsorption, inflammatory bowel disease, or liver dysfunction. Growth retardation can precede the onset of first clinical symptom in these diseases. Growth charting ensures that each child receives personalized care that addresses their unique needs. With the recent onset of obesity epidemic, it is important to plot the weight and height and sensitize the parents for overweight conditions, which is otherwise culturally presumed as a sign of healthy state by the parents. I recommend integrating electronic health records into your practice. This allows for automated data capture, calculation of growth velocities and percentiles, and easy access to growth data for other tasks such as decision support and documentation. By combining clinical expertise with growth chart analysis, we can provide tailored effective care for our young patients. Thank you for your dedication and commitment to the well-being of our future generations.
So dear friends, let's join this movement with Team IIP Mumbai. Let's start using growth charts in our routine office practice and pick up all those faltering growth curves and offer early intervention and early referrals for all our patients. Let's become rational people.
Hello. So we have experts from almost each specialty who have vouched for the use of growth charts, which we've compiled in small videos. And there would be anything better than this that kind of reinforce what we are doing, most of us are doing, but be more regular about it. And in this context, IIP Mumbai has started it's kind of kick-starting basically. So we are making available growth charts in between 0 and 3 years, 0 and 6 years, and 0 and 18 years of the IAP. I mean, sorry, 5 and 18 years and 0 and 18 years. And BMI charts, both for girls and boys in color printed copies, which we will like to give away complimentary 10 copies of each. But you will have to kind of get it accessed from the Scion IAP office in whichever way is possible. So at least we get started by using, and each of our patient has a growth chart within the file that they go next with. Thank you so much.
I think we'll just take half an hour, okay, and just give you a semblance of how much observation also has a power, right?
Before we start, Dr. Nehal Shah, President IAP, has started this initiative. So even in the last CME, we had said, just to make everyone initiate using growth charts, IAP Mumbai will send you a few token growth charts to begin with. So if you wish, please give your names to Vinod, our IAP Mumbai office boy outside, and we'll send you those growth charts. So start using them, and then of course you have to start using on your own. Now let's start with this.
See, we all know that medicine is a science of uncertainty and an art of probability, shed long back ago. We also know that wide spectrum of presentation of every disease has made us feel that anything is possible. Yes, anything is possible, but still has to be based on probability. But the problem is, we hear but not listen, we see but not observe, we know but not think. And I think to that extent, analysis of detailed history and thorough physical examination, of course, suggests a probable diagnosis in majority of cases, but physical examination starts with an observation. And I think right from the time the patient enters your office, while eliciting history, a major contribution to the process, even before touching a patient, is observation. And today again, case-based discussion on observation and give a diagnosis, right? We have not been able to create videos, okay, but we will still go without it. And if people like you can help us to prepare videos, that will be an excellent, right? Let's get about doing that.
So quickly, what all can you observe in general examination? Color of the patient. What else? Posture, weight, gait, activity. So many things. Dysmorphic features, edema, feet, icterus, so many things. Pallor, okay. What about each of the neurology? What all can you examine? So gait you already said. You can look at cranial nerves, state of awareness. You can look at cerebellar signs. You can look at development also by observation. Okay. What about cardiorespiratory? Again, breathlessness, retractions, pulsations on the precordium, cyanosis. So many things you can observe. What about abdomen? Distension all over, flanks, upper abdomen, okay? Veins, musculoskeletal. So joint deformities, limb length discrepancies, and so on and so forth, right?
Are you convinced? We never observed. But here we say so many things can be observed. Okay, it doesn't take time. If you practice, it doesn't take time, and if it takes time, it's worth the time. So let's look at the patient, not just see, but observe. Almost Sherlock Holmes like. And Sherlock Holmes' assistant, Dr. Watson, once he asked him, "Sir, how do you make out?" He says, "You only see, but I observe." We must do that, right?
Okay, so this is a trial round. 6-year-old with purpura, can mere observation suggest the diagnosis? Only observation, 6-year-old with purpura. So first one looks sick. Diagnosis? Meningococcemia or leukemia. Okay. And second one looks not sick and comfortable. ITP. Fantastic. Okay, one more trial round. 2-year-old with edema. Can mere observation suggest acutely sick?
Capillary
Dengue.
leak. We said that in the morning.
Chronically sick. Chronic liver, chronic heart, whatever. Comfortable and happy. Nephrotic. Okay. So now we will start with a few cases for voting.
We'll just select some few cases. Okay, we have again the whole module for 2 hours, but we have no time. Brain gets saturated, right? So,
So 12-year-old breathing fast. Okay. And fairly nourished, not sick, chest movements equal, no chest retractions, precordial pulsations, cardiac impulse down and out. These are just your observation finding, no history, no actual examination. And your options are acute myocarditis, acute rheumatic fever, established rheumatic valvular heart disease, and congenital heart defect. And your voting will start after the music. There will be only 15 seconds of voting, okay? The T20 match has been curtailed to 6 overs. किया कि नहीं वोट किसी ने? Okay. Why established heart disease, rheumatic heart disease? Or why not acute myocarditis? Very good. So not sick looking rules out those. Okay. Why not acute rheumatic fever? One is not sick. What else?
Already there is cardiomegaly.
Okay. So already there is cardiomegaly. Fine. And why not congenital heart defect? तो क्या हुआ? 12-year-old means untreated. किसने उसका close नहीं किया? Fairly nourished. Okay. Fine. So now switch करना. So this is established rheumatic valve. Which heart? Which valve?
which valve is involved? Again, by observation.
Mitral. Why?
Mitral stenosis or regurgitation?
Mitral regurgitation.
Anything else?
Cardiac impulse is down and out.
So mitral regurgitation. Any other just observation will tell you difference between mitral and aortic? Okay, they are there, sir. Precordial are there. So one observation finding which will tell you that this is aortic regurgitation. Neck pulsations or dancing carotids. Okay. So now all of you are diagnosing mitral regurg on observation. Note that. घर जाके जरा ढींग मारना अपना.
I think neck veins are very important to observe also when the liver is enlarged. When the liver is enlarged, you are examining for liver disease, but it could be constrictive pericarditis and the veins will stand out and the hepatojugular reflex will be negative. Diagnosis is made only by observation. Otherwise, the liver function tests are done. So neck veins, don't forget to look at. Okay, this was aortic regurg, neck veins, right? Good.
6-month-old infant looks cyanotic, undernourished, not sick, chest movements equal, no chest retractions, no sound, no precordial pulsations, clubbing of nails, and your options are methemoglobinemia, chronic bronchiolitis, Fallot's physiology, and cyanotic heart disease with mixing lesions like single ventricle. And voting will start after the music. Okay, so debate between the two cyanotic hearts. The first two you all have ruled out. So debate between fallows and non-fallows.
6 month, hello. A 6-month-old infant would not present fallows physiology because that normally comes up around 9 months. Whereas the child is cyanotic heart with mixing would present at a much earlier age.
Anybody else? Any other inputs?
Clubbing would be there in more of a cyanotic heart with a mixing lesion.
Okay. Switch karna bhaiya. Anybody else? So what is different in the cyanotic heart disease with mixing lesions versus fallows? What is different? So cyanotic heart disease we divide in, how do we divide them? So mixing lesions is decreased pulmonary blood flow or increased pulmonary blood flow? Increased, whereas fallows is decreased. So what other finding will you get on observation? So you will get active precordium, or you may get respiratory signs like intercostal retractions or whatever, because they are all more often a combination of failure with mild cyanosis. Yeah, whereas fallows is pure cyanosis, right? So this one is obviously fallows physiology.
So silent precordium is the diagnosis. Okay. Most of the other conditions have some pulsations everywhere.
4-year-old with abdominal distension, well nourished, not sick, generalized abdominal distension, flanks not full, no engorged veins, no edema or jaundice. And your options are Budd-Chiari, recovering nephrotic, large mesenteric cyst, all of the above. And your voting will start after the music. Okay, so start defending. Flanks are not full, so ascites is out. So?
Most likely large mesenteric cyst.
Okay, so ascites is out, so recovering nephrotic syndrome is out.
Yes.
So when recovering nephrotic syndrome recovers, we just switch off a button and everything switches off?
But
so what is the order in which a nephrotic syndrome will recover? What will go first, then second, then third?
So flanks being dependent, they would still be full in a recovering nephrotic.
Okay. And will there be a stage where they will be not full but still abdominal distension? Is the question.
Steroids.
Okay. So therefore recovering nephrotic syndrome can't be ruled out.
Yeah.
Okay. Huh?
There is no edema, so nephrotic syndrome who is recovered will have no edema. Otherwise, they would have edema.
No. So the point is, when a nephrotic syndrome starts recovering, what is the first change that you and I will identify? Proteinuria will stop. Then edema will go. Then there is fluid in the abdomen, which is a lot. So that lot will become less. So when that lot will become less, the flanks will stop being full. And then finally the abdominal distension will go. And by then there will be some chubbiness coming up because of steroids, right? So there are different stages. Okay, what about the other options? Budd-Chiari? Sick child. So all Budd-Chiaris are sick? Budd-Chiaris are not sick. She is fighting. She is fighting when we say Budd-Chiaris.
They are not sick.
Okay. So Budd-Chiaris can be sick or cannot be sick. So
yeah, acute Budd-Chiari is sick. Chronic Budd-Chiari will get sick as the time goes. So again, a spectrum. But what we are discussing really is that flanks are not full. So there is no ascites at present. And that is the hallmark. So could it be a mesenteric cyst or could it be a recovering nephrotic syndrome? Why not a mesenteric cyst itself? Flanks are not full.
So in short, this could be very close to all three with minor differences. The point to note is that recovering nephrotic syndrome will go backwards in some order, and therefore we could have a stage where flanks are not full and yet it is a recovering nephrotic syndrome. Okay? 4-year-old with abdominal distension, malnourished, chronically sick, upper abdominal distension, edema feet, no jaundice or pallor. And options are hepatic tuberculosis, hepatic storage disease, chronic hepatitis, and none of the above. And voting after the music. So this is like all 4 options are possible according to the audience. So let's discuss. So what does each thing mean? Malnourished means what? Chronic. Chronically sick means what? Chronic functional disturbance of some organ, which means if we are talking of liver, it is which component of liver chronic functional disturbance? Chronic parenchymal dysfunction, right? So when you are talking of hepatic storage disease, it is not parenchymal dysfunction to begin with. It is just storage. And the parenchymal dysfunction starts at a little later age.
And storage is in the reticuloendothelial cells, not in the hepatocytes, nor in the biliary tract, nor in the venous system. So the liver function gets upset pretty late in the course. And therefore, there is not storage.
Upper abdominal distension means what? Hepatomegaly for sure, plus minus splenomegaly. Edema feet means what? In that situation of a chronic disease with hepatomegaly, hepatic function is going down, synthetic function. No jaundice or pallor. So now, why is this not hepatic tuberculosis?
Chronic disease, chronic liver disease, chronic parenchymal disease.
Is not common.
Sir.
Isolated hepatic tuberculosis is not so common.
Very good. Isolated hepatic tuberculosis is not there, and we get hepatic tuberculosis as part of congenital tuberculosis, otherwise it's disseminated.
So it must be chronic hepatitis. We said chronic, we said liver, we said liver cell.
Sir, there's no jaundice.
No jaundice. So then what is none of the above? There must be something about the... No?
So those who answered none of the above, what did you want?
So it's a chronic liver disease. It's a hepatocyte disease. So chronic hepatocyte disease without jaundice.
Okay, so this is compensated cirrhosis. Chronic liver disease does not always have jaundice. Okay, so that is this. Okay. 10-year-old with abdominal distension, malnourished, chronically sick, prominent periumbilical distension, no significant pallor or jaundice. Options: Wilms tumor, lymphoma, TB lymphadenitis, any of the above. And voting after the music. So I think majority is any of the above, right? So easiest answer, na? You are always right. Okay. Chalo, debate between Wilms and any lymph node, then we will debate between lymphoma and TB lymphadenitis. Any thoughts? So periumbilical distension means what is the anatomy? What structure is giving rise to the distension? Small intestine and lymph nodes and peritoneum. Three things.
But localized, so it has to be lymph node, right? So we have a lymph node swelling. Which of the two, lymphoma or a TB lymphadenitis?
Sir, malnourished and chronically sick is in favor of TB lymphadenitis.
I think lymphadenitis in TB is a primary complex. We know in the lung. Okay. So it's the primary complex. If you ignore it, it becomes progressive primary complex. In the lung, we know it well. What will happen here? Where is the primary? Intestine. Okay. Therefore, you will start getting intestinal symptoms like an intestinal obstruction, subacute intestinal obstruction of an intestinal tuberculosis, much before it presents as a large tumor. So today, if you find a large tumor in the mediastinum or in the abdomen, and it's a lymph node, almost always it is likely to be lymphoma more than tuberculosis. And this is the basis, okay, that tuberculosis lymphadenopathy is a primary tuberculosis. And at that age, 10 years, primary is not common, but of course it can happen, but not large enough. Much before that, progressive primary will occur. That's why mostly lymphoma till proved otherwise, right?
And because the child is...
This malnourished and chronically sick, things are red herring because lymphoma being chronically sick means how long should be that?
So one is that lymphoma need not always be acute. It can be a little duration. That is one. And for those reasons, Wilms remains a differential in this kind of a observation. So it can also come as a periumbilical mass. So you're right that is a little pointer whether there is something more sick that is going on. Okay.
And I think we all know about lymphoma starts with one area below the diaphragm, above the diaphragm. Till it spreads, there is no much symptomatology except the tumor. But once it starts spreading, you start getting a constitutional symptoms. In TB, that doesn't happen. Constitutional symptoms are present even from the beginning itself. So small differences make it. We must rule out all that, no question.
So the point is that when you have a acute fastly progressive disease, then also you will get malnourished, and malnourished as in your weight will go down and you will look sick. So the differentiation between an acute fastly progressive disease and a chronic disease will have to be fine-tuned based on height, growth chart, so many other things, right? 2-year-old with developmental delay, underweight, length normal, not sick looking, head large, not moving one side of the body. Options: hemiplegic cerebral palsy, chronic subdural hematoma, congenital malformation, and none of the above, and voting after the music. Okay. So anybody wants to speak on any of the voting patterns? Some people have become very smart. They always vote for either any of the above or none of the above.
Underweight but length normal. What is that pattern?
Analyze the findings. Underweight, length normal means what? Acute.
So recent illness. Recent illness. So anything that is not recent is out.
Why is hemiplegic cerebral palsy out? Head is large, so that is out. So now what is take each one. Recent illness and large head. It is not normal head, it is large head. So large head is hydrocephalus. We did in growth charts. So recent illness with large head.
And one side not moving.
One side not moving means infarct. So vascular deficit. So recent illness, hydrocephalus, a focal neurological deficit. What could it be? TBM. So this is TBM with hydrocephalus, TB meningitis. Okay? 2-year-old with developmental delay, malnourished, stunted, not sick, head size large, hypertonic posture, gets startled by noise. Options: TB meningitis, spastic CP, Tay-Sachs and Krabbe's. Voting after music. Fantastic. So everyone got that? Tay-Sachs. So neurodegenerative disease and get startled by noise. Change. 4 months old with developmental delay, malnourished, length poor, not sick, large head size, moves all limbs, tone apparently normal, no abdominal distension. And your options are congenital toxoplasmosis, congenital hydrocephalus, congenital megalencephaly, and none of the above. And voting starts after the music. The none of the above gang is good at it. Okay. So tell us why. First, or forget, let's start analyzing. Malnourished means chronic. Length poor. So in a 4-month-old, if the length is poor, that means when did the problem start? Very early, either intrauterine or right at birth. Okay? Not sick. Large head size means what? Hydrocephalus or megalencephaly. When do we get megalencephaly? In whatever conditions we know. What conditions we know of megalencephaly? Name one or two. Sotos. When do we get? They are tall. Then Alexander and Canavan. When do we get megalencephaly? At 4 months? No. So therefore megalencephaly is out. So large head means hydrocephalus. Now this child is developmentally delayed. So the question is, congenital hydrocephalus, does it cause developmental delay? No. So this is...
Why not? After all, the hydrocephalus is going to increase and have a pressure over the cortex. As it increases. So the point is, all of us have only 4 or 5 millimeter of cortex. And 1 millimeter is enough. We have an option of not using 80%. Okay, so congenital hydrocephalus does not cause developmental delay. It may cause a little learning disability or whatever, but not developmental delay.
So what we have all analyzed is that this problem started either antenatally or soon after birth and gave rise to a hydrocephalus, which is not congenital hydrocephalus because it is associated with developmental delay. So now what can give rise to a hydrocephalus and which happens soon after birth? Come on.
And there is no abdominal distension. Had it been a congenital infection like toxoplasma, CMV, whatever, it would have had also disseminated.
So preterm with post-meningitic or post-hemorrhagic hydrocephalus. Okay? And 2-year-old with delayed milestones, nutrition normal, alert, responsive, head size normal, hypotonic posture, receptive language normal, limb movement and voice poor. Options are polio-like illness, GBS, congenital myopathy, none of the above. And voting after the music. Congenital myopathy. And what's a closed differential? This time none of the above may also be right. What's a closed differential of this? SMA. So it could be SMA or congenital myopathy. Sir, the difference?
I think we will stop at this point of time. We have growth chart and observation of all systems. So point is, any system that you see a patient with, you can use both of these modalities to the best of our ability. And I think that is important. We have taken care of multiple types of common disorders, which we could make out by growth chart, by observation. So I think growth chart, we are going to take a pledge. Every one of us in Mumbai will use the growth chart now. Okay? And of course, we will observe, but Nehal and the company will observe all of us, whether we are using the growth chart. That is also there. So don't get caught, okay? Thank you.
We just want to tell all of you that Sir has inspired all of us to start a YouTube channel called Steer by Dr. Amdekar's team. This is the link of that channel. Every Tuesday and Friday we upload small 10-minute videos on very, very small topics which are useful in day-to-day practice. This is useful not only for pediatricians, very useful for students, general practitioners, even maybe doctors of other specialty. So please promote this to all your juniors, whoever, friends, colleagues, and please visit the channel, see the videos, and like and subscribe and share. And then of course you know that we have lessons from the Grand Round series. The 3rd edition is recently released with new cases. We have the Steer book, we have the office practice book, and we have even when there's a doctor. This book was written by Amdekar sir in COVID period. It is available on Amazon, What Doctors Must Learn. And finally, I think all of you know that we have Thursday clinics for postgraduates going on from the year 2000, non-stop. So we are in 24th year. Thursday evening 6 to 8 p.m. Thank you very much. Over to Sushma.